So good evening, everybody. I am Rahul Choube from Ortho TV, and we are here for our single surgeon live webinar series on carpal tunnel syndrome. And our today's esteemed speaker is Dr. Altaf Warid. He is a consultant hand and upper limb surgeon at Sancheti Hospital, Pune, and his area of expertise is hand, limb reconstruction, microvascular surgery, and trauma. I am handing over this session to now Dr. Altaf Warid and request him to introduce the panelists first. Over to you, Dr. Altaf Warid.
Thank you very much, Mr. Rahul Choube, and thank you, Ortho TV, Dr. Ashok, Shyam, and Sancheti Hospital, for organizing this webinar and giving me an opportunity to speak on this particular topic. And I would like to we are talking today on the carpal tunnel syndrome, which is a very common condition all of us know. So we'll go with the basics and how to diagnose and how to do the management, the surgical part of it. So I'd like to invite I'll introduce our esteemed panelist, Dr. Vijay Malshikre. He's a consultant hand and upper limb surgeon in Pune, in Jahangir Hospital, and attached to various other hospitals. And his areas of expertise are, of course, these peripheral nerve syndromes, and he has done a lot of work on that. Then we have Dr. Aarya Roy. He's from Bhattacharya Orthopaedic Institute from Kolkata, and he also specializes in doing all these upper limb surgeries and hand surgeries. And we also have Dr. Karan Chowdhury, who is again an trained hand surgeon from Calcutta, currently working in Calcutta. So I think I'll start with the talk, and we'll have a panel discussion later on regarding all the queries and discussions regarding this. So I'll start sharing my screen. Yeah, is it visible? Yeah, I think.
Yeah.
Yeah, okay. So carpal tunnel syndrome is very common, all of us know, and we see it regularly in our day-to-day practice. But and sometimes we tender it as a very minor surgery, a carpal tunnel release, and sometimes we see patients like this. So this is really not something good we would like to see in our post-operative carpal tunnel release patients, draining wound and things like that. So things can mess up. Why I have put this as a first slide is that there can be problems. There are associated infections. There are complications related to this surgery. So we should not take it as an orthopedic surgeons. We should not take it lightly. कि छोटा procedure hai, let's do it, and things like that. So we have to consider this as a surgery as important as all other surgeries are, and similarly, take all the precautions to do while doing it and not create complications. So this is definitely not a good side to watch. If you've done something, a surgery, and you're seeing us in a couple of weeks something like this. Similarly, sometimes the patient may come to you with a carpal tunnel release done, and you see and no improvement in the symptoms. So then there are again problems. There's no relief after surgery. So maybe sometimes this is also not too good to see. The incision is way too proximal in the forearm. I think which should be more distal, unless this is an endoscopic release which has been done. But a routine conventional open release, this is probably a wronger site, maybe more proximal. What it should look something like this: an open carpal tunnel release where the incision is somewhere in the middle of the palm, and an endoscopic release, it is proximal to the wrist crease, and which heals perfectly in couple of weeks time. So that is one of the picture of the endoscopic. We'll come to this later on. I'll quickly go through the history. That way back in 1953, Kremer et al. In his article coined the term carpal tunnel syndrome. And then Fallon, of course, all of us know, has done a lot of work in 1951. He ascribed the popularization of the carpal tunnel syndrome. So this was published way back in 1953. And it is the commonest entrapment neuropathy, again we know, and 3.8% of the general population are affected. So this particular figure, I put it always when I talk about carpal tunnel syndrome, is that this anatomy is very, very important. It's a tight fibrous tunnel. We all know about it. There is a hamate, a hook of hamate. There's the tuberosity of the scaphoid, and there's a palmar. This is a bony arch, and this is the carpal tunnel. So this is the base of the carpal tunnel, and that is the transverse carpal ligament. So it's actually a very, very tight. You can call it a fibrous tunnel, and that is somewhere where the median nerve is. So any particular thing causing increase in the volume of that tunnel, physiological, pathological, bony, post-traumatic, rheumatoid, or whatever reasons, it will of course cause compression of that nerve which is there. And once that compression is there, there is weakness of the muscles of the thumb in a chronic compression. Initially, there's sensory symptoms are more. They have pain, burning pain, night pain, and other things. And then later on, the thumb muscles are, which are the intrinsic muscles of the thumb, they get affected. So that we all of us know. And then in chronic cases, you may see thinner atrophy and pretty diminished function of the hand. There are many risk factors. I will not go through all of these, but commonly what we see is hypothyroid is very commonly associated. Repetitive motion, people associate it with particular kind of a job in which there is repetitive motion of the wrist. They also are more prone to develop this, apart from all other causes which you can see here. I think diagnosis, whenever we come to diagnosis, is for me, I think it's always clinical. I usually, and most of the surgeons I've seen, do not rely on EMG and CV studies much, because they do help you in diagnosis. There's no denial on that. But then it is always clinical. You do your test, you see the patient clinically, and before clinically, when you ask the history, the nocturnal ectoparesthesia, that is painful tingling sensation which disturbs the sleep. That is one of the most prominent symptom which they have, and which is more disabling for them. That is the night pain. They can't sleep at night, and which is more towards the medial or the radial three fingers, that all of us know that. Dexterity is lost in late stages, weakness and grip. So that it pretty much is a clinical diagnosis. Again, you do a Fallon's test, you do a Tinel's sign, and then you confirm your test. This particular study again shows a carpal tunnel compression test is one of the most sensitive and specific test. Even more sensitive than EMG and CV studies. In one of the studies that has been shown, then this yellow line you can see, that is the compression test. So it's very much diagnostic, you can say. This was published in 1991 in JBJs, and it is pretty much followed now and is most reliable test to diagnose the carpal tunnel syndrome. And you can see in this graph, if you compare Fallon's, Tinel's compression test, monofilament test, so compression test is which is most 87% sensitive and 90% specific. So once we have diagnosed a carpal tunnel syndrome, there's always have we always have a differential diagnosis in our mind, and we should always have rather diagnosing any condition. So and to rule out the other things. And in this particular case, cervical radiculopathy is one of the common signs. When the patient tells us that there's a neck pain and a hand pain, then you have to figure out which is more, hand is disabling or the neck is more. Where is the compression? Maybe have to do an MRI in the spine, have to look for the local symptoms in the hand, and then rely and come to a conclusion that which is troubling more and which can give more relief. A pain block sometimes in the neck, or sometimes a release, or so that is one of the commonest diagnoses which should be always at the back of our mind. Thoracic outlet syndrome, a little bit on the rare side, but again is one of the differential. Pankos tumor is again a tumor of the apex of the lung, sometimes can mimic a rare condition again, but again always third, fourth in the list. And again, there's Parsonage-Turner syndrome, that is the inflammation of the brachial plexus, again a rare thing. But at least what I emphasize on is that cervical radiculopathy is what should be kept in mind. Quickly, I'll go to the electrodiagnostic testing, because I think most of the people will not probably like going into details of this. But then the goals of this are to localize a lesion, to know whether there's motor sensory involvement, see whether there's axonal loss or demyelination, severity of the lesion, time course of the lesion, and then there's some diagnostic criteria. I've made it a very simple, not really boring. So to see that how to diagnose on the basis of EDS, because most of the times we just go and see the report and we actually don't see what actually they have checked and what is the criteria on that on which we can diagnose a carpal tunnel syndrome. And then the management is a different thing, but at least diagnosing on the basis of EDS. So we see two things: sensory nerve compression and a motor nerve fiber compression. And if sensory is more than 3.4 milliseconds, and that's a distal sensory latency, and a distal motor latency is greater than 4.2 milliseconds, then it's a compression of the nerve. That's how they diagnose it and label it as moderate and severe accordingly. So once we have diagnosed it into moderate and mild to moderate and severe, so that when there's no muscle atrophy, no muscle weakness, and absent innervation or mild abnormalities on the EDS, it's mild to moderate, can be treated conservatively. And severe, when there is muscle atrophy, muscle weakness, severe changes in EDS. So if we at the back of our mind start developing this with categorizing them into mild to moderate and severe, that by way we can manage it conservatively or surgically. But somehow sometimes we have patients with very bad pain, very disturbing the sleep in the night. So I think that they may be mild to moderate category, but they are very much benefited by the surgery, so they are candidates of surgery. So I think it's not a blanket kind of a protocol for every patient. If each and every patient is different, what he requires, what his profession is, what is that how much pain is at that particular point of time, that rather decides that treatment for that patient. And in mild, you can use braces, ultrasound therapy, laser therapy, NSAID, steroids. There is n number of things which can be done, like a local injection of a steroid, workplace modification, nerve glide exercises, and all those things and that. So you will be surprised that most of the times they do very well with the conservative treatment, and the symptoms do go. But there are some group of patients which do not improve. They have that disabling pain. Local steroid injection, again, a very good modality. It gives a very good relief of pain, which can be temporary or sometimes may be permanent, but definitely has a role. A lot of literature studies have been done. A lot of things regarding this steroid injections have been studied, and they all suggest that it has a very effective role. But in most of the studies, they show that there's a recurrence maybe after 6 months, 1 year, 2 years. They do have recurrence, and one of the factors is that when there is an improvement, giving a local injection in the carpal tunnel, steroid injection, if they have pain relief, that gives an indication that that patient will also have a very good result after surgery. So, for example, if we have given a steroid, they have good result for some period of time and then they recur, they are definitely good ideal candidates for surgery. But of course there has to be a gap in between, not immediately of course giving steroid and doing a surgery. So the question is when to operate. I've tried to make it a bit simple. When there's persistent numbness and pain after a trial of conservative treatment, when there's a motor dysfunction, a grip, pinch, grasp, thinner remnants flattening, that is of course when it's pretty late, and severe entrapment demonstrated by nerve conduction studies. And of course that has to be correlated with the clinical symptoms. So this is whenever this, at least in my practice, I see, then I gave an option of surgery. Relative indication is when there's a carpal tunnel syndrome after a distal and radius fracture. Sometimes, very rarely, you can see after we do a volar plating in the lower and radius fractures, then they develop an acute carpal tunnel syndrome. So it is important to know that surgery may be effective even if the patient has normal nerve conduction studies. This is again studied in, this was way back in 2008 in Journal of Hand Surgery British volume, that very good article that which suggests that even if a nerve conduction is absolutely normal, sometimes you can see patients who have clinically very bad pain. However, it's not picked up by the EDS, and you can consider surgery. So that's why in the initial part of my talk, I said that it's always clinical and it's not necessary that you should have changes in the electrodiagnostic studies. So if you feel clinically it is carpal tunnel syndrome and you can justify that, you can go ahead and probably do that. So surgery, again, quickly I'll tell you about. There's a lot of literature on endoscopic versus open. Some people do prefer do endoscopic surgery, some do open, but a lot of literature again on both. If you go and go for the search for the literature, and But all the literature says that over a period of couple of years, the results with both are open. There is a good recovery for endoscopic group. Initial recovery, initial couple of months is absolutely fantastic, maybe a month or so with endoscopic group, but after some time it is same in both the groups. So that's about endoscoping and open. There can be single portal or twin portal. Usually, if we do it here, we do a single portal technique. This is a small animation about how it is done. You take a small incision in the wrist crease, proximal crease, just proximal to that, and you a single portal technique is done. You insert the scope and just cut it for retrograde manner. So that is a very short surgery. These are few pictures of the endoscopic release. This is under surface. The blade is like a triangular kind of a blade, so, and in a retrograde manner, you insert it, you watch it on the screen, you press that button, the blade will come out, and just in the retrograde manner, you can cut the transverse carpal ligament under surface. Only problem is that when you are reaching near the skin, when you're removing the knife, you have to be careful. Sometimes you cut the skin there, you can damage. So when you're almost exiting the wound, you have to be a little careful of changing that angle of that blade. Open carpal tunnel, all of us know that this is the Kaplan's line parallel to the proximal wrist crease and ring finger intersection with that. These are the landmarks. I think this is pretty important because if your incision, particular personal my personal experience is that if your incision is radial or ulnar, maybe by half a centimeter, it becomes a mess. You and unless you see the ulnar, see the median nerve, your release is not done. So you have to see that. So you have to be bang on that nerve. If you're planning a small incision and you have to adequately release it, you have to be right on the top of the nerve. So landmarks very important. I think that's the Kaplan's line, and then that is the that's the incision. It's slightly on the ulnar. If you see the center of the wrist, maybe slightly on the ulnar side, and then you that's that is the transverse carpal ligament. You make a small nick, and then you put your McDonald's retractor, and then you cut over it, and that behind that is where what you can see is the ulnar now. And then you flex the wrist, go towards the hand side, and flex the wrist, and then cut the forearm fascia and distally till you see that fat pad sign that completes your distal release. So adequate release is very important. This is a small video. I'll quickly run this. So what I was telling is that adequate release of the carpal tunnel is very important. I think most of the times, if the patients do not improve after surgery, is that the release has not been done adequately. I think diagnosis most of the times we are bang on. Everybody does that, and but if they don't improve after the surgery, one of the possibility is that there's an adequate release. So that is the Kaplan's line where this intersect. This particular case had a distal and radius plating done 1 month back and had an acute carpal tunnel syndrome, and this was referred to us. And then we did a carpal tunnel syndrome release this thing, and had an amazing recovery after that. So that is the incision. You can take that incision there, and then once I'll just quickly go. You take an incision. We do it under local anesthesia, most of the time under a forearm tourniquet kind of a thing. And then once you are there, so yeah, there you can see you make a small nick, and then you insert your McDonald's in the carpal tunnel. So I think this particular point is important. That is the transverse carpal ligament. And when I make a small incision with a 50 number blade, making sure not going deep. And once that small nick is made, and then I try to yeah, there you can see, and that is the median nerve popping out, kind of. So yeah, so then we insert the dura retractor, and then go in the palm and towards the forearm, and that completes the release. So I think that is again an important message there. So this is again we are going to the uh, wrist side. So that completes the release, and now you can see nicely, you can see that nerve there. Yeah, so you should always check your distal release, your proximal release, and be sure that it has been adequately released. And then usually not more than 2 centimeters this incision, and this was the X-ray of that particular case that we were discussing. That sometimes it does develop after plating of the lower end of the radius, and this maybe in this particular case. A more heavy duty proud plate has been put distal to the watershed line, and it's not very slim, so maybe that has gone that has led to this. So this was too early to remove that implant because it was just nearing a month old surgery. So but patient had a dramatic relief after the surgery. So again, complications. Again, the first slide which I showed you was the complications. So complications are associated with every surgery. Similarly with this, so a palmar cutaneous branch can be injured. Try to remain on the ulnar side of your incision. A recurrent motor branch can be injured, which 20% times is transligamentous with recurrent innervation. So when it is transligamentous through the ligament, you don't know where it is crossing the ligament, and 20% times the recurrent motor branch is transligamentous. So you cut the transverse carpal ligament ulnar on the ulnar side of your incision, so that you save that, and also the carpal tunnel is narrowest near the hook of the hamate. I told you about this is injury to the recurrent motor branch, palmar-cutaneous branch. Hypertrophic scarring sometimes can give a lot of pain to the patients, pillar pain, what you call it, and then sometimes a laceration of the superficial palmar arch. If you go more distally, you may cut that, and there's torrential bleeding, which is very difficult to stop sometimes. Tendon adhesions, of course, surgical site infection. I showed you that, hematomas, stiffness, and other things. Revision carpal tunnel syndrome, incomplete release is the most commonest reason for failure to improve after primary surgery, which I mentioned earlier once, that a lot of literature has been uh, is on that, and they do suggest that incomplete release is one of the common problems. Prevention, avoid stress on the wrist, proper posture, exercising to strengthen the fingers, good nutrition, avoid smoking, and limited alcohol intake. Thank you so much. I'll stop sharing. Yeah, I request all the panelists to please unmute, and we can probably have some discussion on this.
Warid, Dr. Warid.
Yes, Dr. Aarya.
Yeah, thank you for nice simplified. And I actually I myself also I also like any problem if you are approaching, your approach should be simplified so that and you can make best of it. So I think your lecture was very nice and presentation was very nice.
Thank you.
So, but I just wanted to uh, remember when I was in Ganga, the sir, Professor Dr. Raja Sabapati, he
Yeah.
used to say that this, you see, I don't do all the big short surgeries like you say this brachial plexus, implant, all this. You see, I never do it. Oh, sometimes they call me, I go. But most of the time, you see, I do carpal tunnel, I do this mallet finger, I do small things.
Yeah.
Because the reason behind he says that these all are zero tolerance cases.
Exactly.
You have no scope to, I mean,
To
if
do something
anything,
wrong, to make a
yes,
mistake. Yeah,
you have
exactly.
no scope of making a mistake. So you need to be very cautious. So that is why he used to do all those cases.
Yes.
So that is the first. And secondly, hmm, I in my personal practice, what I have seen that most of the time your patient selection is very important because as you said in your lecture that there are many systemic causes.
Yeah.
There are like most importantly you see diabetics.
Yeah.
When there is peripheral neuropathy, and I think I maybe I missed there is a term called double crush.
Double crush, yeah.
So in those cases, in those cases, sometimes you may release it nicely, you may release it completely, but still patient may not have the ideal outcome.
Exactly.
So that is what I actually, the first I was thinking that I will mention.
Correct. Okay, thank you for your words. I think Dr. Vijay, you have any comments or questions?
Lecture was very nice.
Thank you.
Basically, you have covered all the things which has to be noticed by all the orthopedic surgeon, and it is very simple and lucid. Uh, Regarding one thing, I want to highlight that nowadays my incision is because people are saying I am doing with the 1 centimeter incision, 2 centimeter incision. But
Correct.
once I learn and I was with my experience, my incision is little bit extending from 1 centimeter to the 5 centimeter, because I prefer to do extended incision, because lot many times there are the variations and we don't know the variations what is happening in the tunnel. So in my practice, I always do USG to see whether there is any abnormal muscle, abnormal artery, recurrent branch, or even palmar cutaneous branch. It has got a variation. And once you cut that nerve and everything seems to be very good on table. But after some month, patients start crying because of that neuroma. And carpal tunnel is a very, we say 100% good surgery, because results are very good. Next day patient feels there is no numbness and everything, and after 2 months it started from the non-pain palm to the painful palm.
Right.
So we always as a hand surgeon do USG. I want to just share one case which is recently I had did, because I do USG, but still I miss that abnormal course of palmar cutaneous branch. So
Yeah,
if
that's
you have
what I
got
want
some
to-
times, I can.
I
Hello,
have one question
can
on that.
I share? Yes.
So does it pick up if you do your USG for all the patients? If there is an
Mhm.
abnormal anomalous branch of the maybe recurrent branch of the median nerve, so is it always picked up,
Mhm.
and or
Yes.
does it relate with that?
Yeah, because if the sonologist is good and he is a musculoskeletal sonologist, he
Right.
should pick
Correct. Correct.
with a high frequency probe,
Okay.
and it is very superficial now. So I don't think so. It is has to be missed because it is
Right.
very superficial now. It is not a deep like a posterior introsseous now.
Right.
So I think, and even one thing also, always we are not doing carpal tunnel view. So it is a good idea to do a carpal tunnel view, so we can see the, because we are not assessing the bony abnormalities. Because once we do the carpal tunnel, because Dr. Even Anil Bhatt sir is also insisting on the carpal tunnel view and USG. So
Right.
I have started this. I
Okay.
want to share one case which can I, if
So,
you have got a
we
permission, I
can
can
share
share
it
it.
now, and then we can have a discussion on that.
Okay.
You
Okay.
can start sharing
Yeah.
because we have time. We have another 20 minutes at least, so we can.
No problem. No problem.
And also the post-up any roll up any splint, and that
Yeah,
also we have to.
even I had that question for everybody here till the time
Hmm.
the presentation is loaded for Karan and Vijay sir. That do you immobilize your patients post-op, and how do you, and for how long if you do?
So, okay,
Karan, you
Vijay
can
sir.
take that first. Yeah.
Sorry, should I take the question?
Yeah, you take that first. Yeah.
So, I had asked once Sabhapati sir when I was in Ganga that why do we immobilize the hand? So he just told me that we want the patient not to just the wrist should not go into flexion. And because the brachial block has been, I mean, all the carpal tunnels have been done under brachial block. So for the first, I mean, for the first 1 or 2 days, I mean, because of the lack of motor control, the wrist may just go into flexion. So just
Yeah.
to prevent that, it is splint is given in a neutral position. However, in our practice, because we are doing this under local anesthesia, we are not giving any sort of splints. It's just a soft bandage dressing. So
What about you, Dr. Aarya? Do you give splint?
Yes. I was just, I also actually, what happens when you release the carpal tunnel, there is theoretically that the arch becomes more flattened, right? The concept of all those, you see, pillar pen and all.
Right.
So when that happens, so there is a possibility of bowstringing if you put it in flexion or something like that, or
Right.
maybe extension in fact. So sometimes some doctors, they say that if you put it in little bit neutral or little bit flexion, it's good, rather than complete little bit of extension, because that may cause that
Yeah.
bowstringing thing.
And scarring, yeah.
I don't know whether, because I always used to do the neutral position, at slab in neutral position, just because, as Dr. Karan said, for that reason.
Okay. Perfect. Let's see this presentation. Dr. Vijay, you can start quickly.
Yeah, am I audible?
yeah.
Yes, absolutely.
Hello? Yeah. Okay. So this is the case, 52-year-old male, farmer by occupation, bilateral tingling and trophic ulcer on medial nerve distribution since 4 to 5 years. Basically, dermatologist was treating for ulcer because nobody knew, dermatologist not knew that it is a carpal tunnel syndrome. So he was taking a medicine for 4 to 5 years. Still, there is no relief. This was the clinical. There was a bilateral ulcers on the palm with a median nerve distribution. Since sensation was decreased, motor weakness was there, and on NCV there was a clear-cut carpal tunnel syndrome. So as I told, I do always a sonography. The sonologist has given me all the dimensions of the nerve, retinaculum, and every single detail, but he doesn't give me a palmar cutanous branch location and a recurrent branch location. So I have opened this case. So I have seen this is the persistent median artery, and when I open it, and initially it was very small incision, as you described. I opened it, and when I do a proximal release, I noticed that I have damaged the palmar cutaneous nerve of median nerve. So because if you see, this is a palmar cutaneous nerve of median palmar cutaneous nerve. Basically, it has a course, and it is supplied to the radial side, but it has been crossed to the hypothenor side, and it is supplied to the hypothenor skin. So because I have cut it blindly, so cut the foramen fissure blindly, I have damaged this nerve, and it was not picked up on the sonography. So I have extended the incision, mobilized the nerve, and I have repaired the nerve with a 80 nylon. And if you see, after 15 days post-op, recovery was very good, and even ulcer is gone here. Can you see this? Because
Right.
previously it was here ulcer. And hello, hello, hello.
Yes, we can see that.
Yeah. So this ulcer is also healing in 15 days. Now I have did a right side. After some days, I will do a left side. So this take home message is we have made a very strict protocol myself. So I have to do carpal tunnel view to see the bony abnormalities, and every case UH is the must for me. Order for tell your sonologist that you should give a location of percutaneous branch of median nerve. If there is an aberrant artery, you should mention muscle, position of recurrent branch. And if you are, don't be a liberal with the incision that I should do in 1 centimeter or 2 centimeter. If you in doubt, you always extend the incision and do the proper carpal tunnel release. So thank you very much. So if you have any questions,
Yeah, thank you, thank you. Yeah, that was a wonderful case, I think.
Yeah, wonderful case. The thing, Dr. Vijay, I just wanted to
Mm-hmm.
just to make myself more to give me clarity, more clarity. That
Yes,
if,
sir.
as Dr. Warid said, that there is a how many
Mm.
percentage? 20%, I think. That there is a trans
Transfer.
TCL. Yeah. So in
Uh-huh.
those cases,
Yeah.
if you can, even if you can find it by USG, uh, how would
Uh,
you I mean, what will be your, I mean, if it is traversing the, I mean, piercing the TCL, and
yes.
it will be very difficult to, I mean, I have never came across, but I have no idea how to release that.
So, so what happened if the sonorist says that this is crossing? So I will
Hmm.
go from proximal. I will trace first palmar cutaneous branch, and then I will follow that palmar cutaneous branch, and then I will divide the flexor
Okay, so
epigastrium.
you dissect the palmar
Yes,
motor
yes,
nerve.
absolutely. Because
Uh,
no, no, palmar cutaneous now.
Talking of
yeah.
cutting.
First,
Yeah.
No, no, I'm not. Asking about the motor branch of.
motor branch, motor
Yeah,
branch, motor branch. You have to extend the incision.
yeah.
Yeah,
Okay.
You have to extend the
And
incision.
you dissect it and you see it, then you release, right?
Yes, and there is a good practice to tag the nerve. You always tag the nerve with a silicone loop. So it will give you a clarity because this is the median nerve. You get away from with the loop, and then you tie another loop to the recurrent branch, and you can pull that nerve to see whether it is stuck or it is moving. So better to use that silicone loop is
Okay, I
very
have
good idea.
I have one question for all.
Yes, yes.
Uh, what kind of anesthesia do you do in local or brachial or short GA or what?
For me brachial,
Okay,
under tourniquet. I do it
under
under
proper
tourniquet, brachial.
arm
Yes,
tourniquet.
And
yes,
magnification.
and
Magnification
magnification.
is
Yes.
there.
Yes,
Is common.
there.
Is
That is
common.
no,
Is common.
but nobody is doing it in local anesthesia.
I am
No,
doing
I
it in local.
no, I'm not.
no. Some cases I do in Valent. Some cases I do in Valent.
Vijay sir, I have a question. I
Yes.
mean, what in carpal tunnel view, what sort of bony abnormalities do you have to see for in carpal tunnel
Any
syndrome?
cysts?
No, but in X-ray,
Yes. Any
the carpal
cyst?
tunnel cyst you can identify,
If
or you will do a
yes.
sonography only
If
to in the sonography only you
no, no.
can
I
see
will
a
do
cyst
both.
or no. But what do you want to see in
Yeah,
X-ray?
but
That is my question. What abnormality? You are saying for the
X-ray.
bony abnormality. So what bony abnormality?
Yeah, and
Yes.
to add to his question, Karan's question, I will also add a
Hmm.
continuation with that. For example, there's a bony abnormality. Maybe sometimes in rheumatoid arthritis
Hmm.
or a malunited, some of the carpal bone fractures
Osteophytes or
there,
something.
and there's a post that is the carpal tunnel syndrome. So does the release will be the treatment? I think that will not change.
Yeah.
There is
No,
any.
that will not change. But in future in medical legally you will be safe. No,
Yeah. Okay.
medical legally you will be safe.
And I have one more question. Like, do you do EMG NCV in all or
Yes.
Yeah,
Yes.
in
that
all?
is.
Yes. Yes.
Warid, that
Yes.
was my
Yes.
question also. That is it
Yes.
necessary to
Yes.
do NCV EMG for each and every cases you operate?
Honestly
That
speaking,
is.
I don't do it in some of the cases where I'm short about the diagnosis. Patient is knowing that we have a
So
conversation.
clinical diagnosis is enough,
Clinically.
right?
So
Yeah.
clinical diagnosis, I mean, the investigation would be just to back up the clinical findings, nothing else. It's
Yeah.
just
Sometimes
Yeah,
the patient.
medical legally just to back
but
up.
medical legally you will be not in the trouble because it's your judgment that clinically you have find that this is a carpal tunnel syndrome.
Hmm.
But somebody says it is not carpal tunnel. How will you judge in a court
Hmm.
of law? How will you judge? And how
Yeah.
will
So
you defend
legally
yourself?
that can create a problem. That can
Hmm.
create a problem. I
Yes,
think.
yes.
Sometimes in one case I had to do it because of you see, I have clinically, I asked for the surgery and the patient was ready, but his insurance company was not
See,
convinced.
I can make one point that most of the times we are pretty much sure that it's a carpal tunnel syndrome and the patient will be benefited by surgery. I think most of the times the situation is that.
Yes,
And sometimes the patient enough is they are intelligent and वो बोल सकते हैं कि अरे डॉक्टर साहब आपको पता है ये है तो फिर
yes,
क्यों
yes.
काय को टेस्ट करना है Yeah, sometimes something like that. If you are sure that you have it, or at your back of your mind, you know it is it. I think, I don't know.
Have
Medically,
you
Yeah.
ever, I just have a
No.
question. Have you ever faced a situation where the EMG NCV shows positive carpal tunnel syndrome and a neurologist is referring it to you saying that iska carpal tunnel surgery kar do, and then you feel that it is, I mean, not that necessary or something like that. I mean, the EMG's NCV is showing a grade. They have their grades of carpal tunnel compression. So
yeah,
it's showing a very high grade, but then clinically it is not that
I
high. And
honestly speaking, I do it in maybe 80 to 90% of patients. If I take that question first, I do it, but I don't rely on that, and my plan of management will not really change depending on severity based on on the electrodiagnostic studies.
Exactly, because
Yeah,
if you can give relief to the patient, that is the thing. Whoever suggesting you the surgery and all that, those are, I mean, it is not, I think, significant to take care of.
Vijay, Dr. Vijay, maybe you can add. Dr. Arya, we cannot see you. Your camera is off, I think.
No, basically this AMG NCV should be done because of medical legal purpose, because
Yeah, yes,
nowadays
true.
everything is yeah.
No,
So
absolutely. That is,
so
we
no question about
agree.
it, because if you not do and anything happens, then patient will say that भैया मैंने तो बोला था आप डॉक्टर हैं
Hmm.
तो
Ah,
आपको समझना चाहिए था.
yeah, absolutely, absolutely.
So they will
Now,
always
we,
it's two
the
way.
that is fine. That is fine. But the trained musculoskeletal USG करने वाला सबके पास तो नहीं है. आप लकी हैं. आप लकी हैं कि आपके पास है somebody who gives you,
No,
so
no, but
nice.
everybody can teach it. We can train it. You can train it, because if you have your friend, you should always say to him, "भैया ये करो." You start it. For
Yeah,
in case it will
you
take
always
a little
preach.
bit dicey.
We have
Yeah,
to
you
talk to
always preach about
radiologists
this.
and tell him to look
Yeah,
for it. They will
always.
definitely
Yes,
see.
we always.
I have a question, like the role of
Now, if you are
pharmacotherapy. Hello.
Yes,
Yes,
yes.
go ahead, please.
So the role of pharmacotherapy. Do you
yes,
use like which all medicines? Do you use pregabalin or Lyrica in management, conservative management? What all protocol do you follow?
I
I'd
can
like to
take
ask
that first.
panelists here, all the panelists.
I think I'll take that first, and Dr. Vijay and Arya can take. I'll give one splint for day and night.
Hmm.
No glide exercises. One
Tendon gliding.
pregabalin, one vitamin C, and maybe uh, one NACID, heterocoxib or something,
Okay.
and watch for 3 weeks.
Hmm.
And if
Yeah.
then accordingly we.
Yeah. Yes, I also follow that, but I routinely don't prescribe this pregabalin thing. I give it if they are having peripheral neuropathy, having diabetic or something like that, and then I actually think of pregabalin. But I mostly in normal patients who are having isolated this kind of problem, I don't prescribe pregabalin.
Okay.
Dr. Vijay.
okay. So I start NSAID for splint is my first. I never give steroid.
Okay.
Never. Because
Anyone gives
accidentally
oral steroids, huh?
oral steroid also not
No,
oral
no,
steroids.
Deflazacort
no.
6 milligram
No,
0.6.
No.
Okay.
I don't.
But we
I
are
don't
seeing,
think.
I think
Even
many
in,
do prescribe that, and I see patients coming
yeah,
with
yeah,
prescription of taking a lot of steroids for that. Yeah.
yes.
I
Hmm.
have one more question. Suppose the EMG NCV, I mean, clinically it's a carpal tunnel syndrome, but then
Yes.
EMG NCV is showing a TOS with a carpal tunnel compression.
Mm-hmm.
So how to go about such a case?
Means
Would you
EMG is
do
showing.
the EMG NCV, the EMG is, sorry, the EMG NCV is showing a thoracic outlet with the carpal tunnels, this thing. So it's a double crush,
Double
Yeah.
crush, yeah, double
uh,
crush.
Double crush.
double crush or a triple crush, whatever. So how do you go about such? Is it just
So,
pharmacotherapy?
Dr. Karan, if I take the question first, in cases where the peripheral nerve is compressed in 2 or 3 places, the threshold becomes low. The threshold of symptoms become low. So, of course, where you have no access, that is second that should be think later. But once we know that there is a TOS and there is a carpal tunnel syndrome in same limb, I think the release of carpal tunnel will give the patient much more relief. You may treat it after by physiotherapy or something, maybe whatever the treatment is there. But of course, in double cross, of course, you do the surgery first. It will give patients immense relief.
What is the role of giving a xylocaine in the carpal tunnel, and see in double crush diagnostic test like NIRS we do in the shoulder, that kind of test, doing giving a xylocaine.
Yeah. That is a wonderful test to rule out.
The double crush.
That, as you
Double
said,
crush.
na, that who are giving positive result, they have very good, I mean, post-operative relief.
So yeah, positive lignocaine.
Dr. Aarya had said that when there is a double crush syndrome, mostly we have cervical disc with a carpal tunnel syndrome, and if you are released, they have a dramatic relief even for their neck pain. I don't know.
And Warid, to add on that most of the time in cervical radiculopathy or lumbar radiculopathy, actually I have spoken to spine surgeons also. Most of the time it is chemical. It is not compression. Most of the time, I'm saying most of the time.
Yeah.
So the spine surgeon or whoever, they will treat that. They will give some splint exercise, whatever. I mean, so by the side, if you do the release of the carpal tunnel, it will give of course, very good relief to the patient.
Agreed.
I would want to ask the panelist regarding the anomalies that we encounter in the carpal tunnel. So you do a sonography, Dr. Vijay, you do a sonography for all the carpal tunnel to see for anomalies of muscle, tendon, and then for any vascular or neurogenic this thing of a bifid median nerve for all cases.
After this case, I have started. I have burned my fingers now, so I have started. Because everybody started after burning the fingers only. Until now, 10 years, I was happy with the mini incision. I was very happy, and everything was nice. But once this case happened, I was very cautious about this. I will ask my sonologist to give me each and every detail. I have ordered him to do one chart and tick mark. This is I have done, and this is the finding, and then only I will touch the patient, because I have burned my fingers.
Yeah, it is just like akin to a CT scan for a proximal tibia fracture now. I think sonography of
it is cost effective also.
It is difficult to you sell this by saying that it's a small surgery, it's local anesthesia, or it's minor, no tests, things like that. Then we keep on adding tests to ADMG and I don't know.
But who are having those very worse symptoms, they will do each and everything whatever you prescribe. I mean, they cannot sleep. They cannot sleep. The night pain. They cannot sleep. Even I'm sharing with you my wife. My wife is having this thing, and she's crying in the pain when she woke up, and she's crying in the pain. It is very bad. I mean, it is. You cannot give it. It's a minor thing, and this and that, but the pain is
really bad.
As good as fracture or something like that.
Okay, one question. Anybody have tried vitamin D injection in carpal tunnel? Because recently, lot many papers are coming, and even is also doing a good work on
I would
this.
like to take this question. I always, as a part of pharmacotherapy, for the first consultation, I always give 2,500 international units of vitamin B12 and 6 lakh units vitamin D Erekitol for 3 injections each, and at a duration of every alternate day. So this would be the management. So if in case patient has a vitamin D, so there is a dramatic pain relief, the symptomatic relief of carpal tunnel.
Yeah,
This has been my
I
experience, and
But
no no this
but
this is the
no, no,
yeah
but
I also agree. Yeah, tell me what
but each and every patient, yeah, each and
yeah,
every patient, because you do a vitamin D level, or haphazardly you give a
no,
vitamin D.
haphazardly we
If
give.
he
I
has
mean,
got
not haphazardly,
vitamin D.
but we suspect. I mean, it's just a vitamin. It's just a nutritional supplement, like so. If the patient has
uh,
a deficiency, it
Okay,
gets
but
cured.
yeah, but if he has got a hypervitamin, then vitamin D hyper, then
I don't know. I mean,
I would take the history if the patient has been taken vitamin
uh,
D supplementation. I think it's
uh,
a good point that you mentioned. If the
uh,
patient has been taking vitamin B, if he says that he has received already injections, then probably I would, not give any injections. So I would take his previous history. I mean, the medicines that he has been taking. If it has already been supplemented,
and
then
what?
I will not supplement. So I would
Not
not do
yeah
any specific
that's the point.
investigation because I mean it is all everything
Okay.
is a cost, no? I mean that's why.
yeah.
So
Yeah. Everything comes with the cost.
with a cost.
Dr. Warid,
yes.
this I mean when you are you see patients are always not ready to get operated, right? So sometimes you need to delay it a little bit. I mean, maybe 1 month, a couple of months, maybe there is a marriage or something like that. So a night splint with a vitamin D actually having very good result. I am very, I mean, agree with Dr. Karan. Myself, I tried in a few patients and because and they came back. They came back when I mean those 2 3 months gone, and then again actually the problem is there, right? So they understand that, but you can delay it by giving a good night's sleep
You
and
can delay it.
shot of vitamin D,
Once
as
needs the
Dr. Karan
surgery,
said.
he will definitely come back. That is for sure.
Yeah.
Yeah.
So
So
whenever
let patient buy a surgery.
yeah,
Yeah.
yeah. So that is the approach towards the nerve surgery. Let the patient buy the surgery and
Let it buy. Let's is
exhaust
the
all
most
the
important thing.
conservative
That let
yeah.
surgery buy.
Yes.
Mm.
Let us exhaust all the conservative modalities that we are known to mankind before the patient, I mean, buys the surgery.
Buy surgery. Yes.
So
So
that
I
would be
So
never.
the
the
message.
So
I know.
I think we'll I'll
We
have a
will
last
conclude
question.
this.
no.
Yeah.
Sorry, can I ask you something?
Sure.
So in cases where there is a little bit of atrophy of the thinner muscles, so already it is when it is late. So any point, any, can you throw some light on that?
I think at that particular point of, you mean to say when it is very chronic and the nerve is already.
Yeah, chronic is
Yes.
already thinner, hypertrophy.
I
I
think
mean,
personally,
yeah,
when I
atrophy.
see something like that, because of the lower median nerve palsy, I mean, at the carpal tunnel, if it is chronic, if they have pain, they if they are painful at that
Mm,
particular point of time, I would still consider it, and of
mm,
course, checking a position of the thumb, and
mm.
you can do a release plus the gamete transfer to give them a good.
Yeah, yes,
They will
yes,
probably have a
yes.
bad
Yeah,
functioning
it
of.
is a that is a very good point. I mean, that should be always thought of, because you see, if patient cannot move his thumb,
Yeah,
that is the worst scenario which can happen. So you, when you release, you just take the strip of the fascia
correct.
and
Wrong. Yeah.
rotate it towards the, so it can give some better result
It is
for
good
that
result.
patient.
We did it in couple of patients, and they are doing pretty good.
No, one question. If there is a thinner wasting, a position is lost, okay, and carpal tunnel, you will do same time, or you will first do carpal tunnel, wait for a recovery, and then you will do the
Same time, same time.
abdominoplasty.
I think same time is okay,
Time
because
is justified.
Extended incision to the wrist and same time this.
Yeah.
Same time. So you prefer same time.
Yes, yes.
You will not wait for a natural because all compression it recovers nicely.
It's recover, yeah.
So
But
APB, I would
they are
want,
usually elderly and
yeah.
debilitated. It's better to give them good function.
Patient selection is important.
yeah, that is true.
Section,
That
yeah,
is the
maybe.
main thing.
That
Yeah.
is pretty
Yeah, yeah.
It is very difficult in, you See, you tell
Every surgery,
your,
for that
you
matter.
tell, yeah, अभी एक कर रहे हैं, फिर अभी थोड़े दिन बाद फिर से करेंगे. ऐसे बोलने से, it's very difficult.
No, patient selection is very important. In carpal tunnel,
that is
patient
that.
selection is very
It
important.
is very important.
So I have a point to make. So APB, APB wasting is indicative of axonal loss. So we have to see whether there is a compression causing demyelination or there is an axonal loss. So APB axonal loss means the disease has progressed to a, that means that carpal tunnel release alone may not work. That it means that if the APB is wasted. And at that point of time, I have seen that the patient doesn't have that, is not that much symptomatic. He doesn't have any night pain, just that there is a wasting and weakness in the grip and loss of dexterity, what you showed in your talk.
Yeah, I
So
think
that
that is the point where EDS is more important. I mean,
is more
Yeah,
important.
EDS.
studies. Then in early stages where we know it is, carpal tunnel syndrome.
So then doing, it's the same incision with which you are doing the carpal tunnel. So main, we want to give a opposition to the patient.
Right.
So carpal tunnel is done through the same incision. Although the APB is not that, the Camex transfer is not that strong a opposition this thing. So we have to see the functional demands of the patient. If it's a frail lady who has a low functional demand, then APB, then the Camex transfer is a choice of opposition plasty. However, if the patient's demand is more, then we have to choose our options likewise.
Yeah, true.
One last question. Nobody has talked about endoscopic carpal tunnel. Do you prefer or not?
Yeah,
because in Western world they are using left and right.
Yeah. See, so I think I'll take that quickly because I did mention it. We do very rarely do it, but I think honestly the long-term results are same. And in Indian scenario where we are operating on the patients, it is maybe some particular patient maybe
no,
but
particular patient like if patient wants early mobilization because he wants to see that he doesn't want a slab for 15 days or any, he want to go to work in next day.
Yeah, no pillar pin.
So endoscopic carpal tunnel like a IT guy. So and even open carpal tunnel also cause a pillar pain. Some cases. So in endoscopic carpal tunnel only one stitch. Next day patient can use the hand, use the mobile. Nowadays mobile is very important. So they will use because they ask the question, can I use the mobile next day? So if a patient demands about the endoscopic carpal tunnel, again doing endoscopic carpal tunnel, again we have to do a sonography because abnormal branch and everything.
For that, so, it is very important. It is because
very
it's
important.
blind procedure.
Very important.
Yeah.
Yes, it is blind procedure.
Yeah.
Yeah.
So
what do you do endoscopy?
We do. Maybe 1 in 2 to 3 months. Only when the patient. I am not personally a big fan of this endoscopic because the cost goes extremely high. It goes 4 times in our hospital. What is for the open? So I do it very.
But you give the option. You give the option.
No,
first
I don't give. I think I've only done it on patients who have come for that. Endoscopy ki karwana. Yeah.
Okay.
So EMG, NCV, and sonography. These two are the investigation of to be considered before surgery. Before surgery.
Yes, absolutely.
Surgery. Yeah.
Perfect. I think generated a very good discussion and on a topic which is very common for all.
Yes.
I'm hopeful that the audience who is watching us will be benefited out of it because most of the
So Warid, conclude.
So I think we'll conclude. Yeah. I'm very thankful to all of you. I mean, Dr. Vijay, Dr. Karan, Dr. Aarya, you have taken out your time. Dr. Aarya just finished with one emergency surgery and he has joined us. Thank you so much for that, Dr. Karan.
Thank you.
Dr. Vijay.
Thank you, Warid.
Thank you.
Full discussions on.
Hopefully we will have again meeting.
Sure.
Another session.
Have, on the interesting.
Yes.
Definitely.
Hopefully on radial.
Thank you very much.
Yeah.
Thank you very much.
Okay. See. Okay.
Yes, Dr. Vijay, what happened?
Yeah, I want to add last closing sentence that I operate all RTS syndrome. Okay. in my practice, I operate RTS only. CTS is very less for me.
We will have webinar on that. RTS.
Yeah, we will have.
No, yeah. Okay, thank you very much. Bye.
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 Okay, thank you.
Huh?